welcome everyone to ISOT midterm. So my topic is antimicrobial stewardship, and first of all we will talk why the UTI in transplant is so important. The objectives of this talk is to understand the unique challenges that post-transplant UTI the patients face, and to review the evidence-based antimicrobial stewardship strategies. So UTI in transplant, it is 3 to 5 times the UTI in general population, and about 3/4 of all transplant recipients, kidney transplant recipients, they will face UTI in post-transplant period. So WHO has given a priority list. They have prioritized the with different microbes, most concerning AMR pathogens, and as per them, the gram-negative bacteria is harder to treat, and they have prioritized it over gram-positive. In gram-negative, it's CRE, the carbapenem-resistant enterobacteriaceae, then multi-drug-resistant pseudomonas, extensively drug-resistant acinetobacter. These are the most prioritized infections. And in gram-positive, the most prioritized are MRSA, vancomycin-resistant enterococcus, and Mycobacterium tuberculosis. In study, multi-center study we had done, in past decade, if we see the antimicrobial resistance in first 5 years as compared to last 5 years, the Klebsiella, E. coli, and Pseudomonas, there is drastic increase in antimicrobial resistance. So talking about the resistance patterns, there are two main patterns of resistance. One is ESBL, extended spectrum beta lactamase, and CRE, that is carbapenem resistant enterobacteriaceae. In extended spectrum beta lactamases in India, the Klebsiella ESBL, it's more than 70%, and it's more as compared to global incidences. And CRE, the incidence in India of Klebsiella CRE, it's more than 75%, and that of Acinetobacter baumannii is more than 80%, and it's well above the global incidences. So what are the global and the regional trends? Talking about the global GLASS data, the incidence of ESBL and CRE, it has increased in all WHO regions. The CRE emergence in community infections, and it's more now as compared to previous incidents when it used to occur in hospital-acquired atmosphere. But now it's been, we are finding the CREs more in community-acquired infections also. As per the ICMR report, which was published in 2023, more than 75% of Klebsiella isolates, they are resistant to carbapenems. And ESBL rate, it is rising in outpatients also. So we are now getting outpatient patients also, which are suffering from infection, which are ESBLs. So what is the clinical impact? Why we must act? Because the AMR, it leads to higher mortality, more chances of graft rejection, more chances of hospitalization, and there is increased economic burden. What are the current guidelines? So as per the American Society of Transplantation, it says that for antimicrobial, regarding the antimicrobial resistant bacteria, in asymptomatic bacteria, they say we don't need to treat asymptomatic bacteria which are multi-drug resistant. As per WHO and CDC guidelines, they promote restriction of use of broad spectrum antibiotics. They promote de-escalation strategies. They encourage use of local antibiograms, limit fluoroquinolone prophylaxis, and they emphasize the preventive measures for UTI. Regarding the IDSA 2023 guidelines, in complicated and recurrent UTIs, they stress upon avoiding empiric carbapenems. They use beta-lactamase inhibitors and beta-lactams, and to consider IV aminoglycosides and cefiderocol for carbapenem-resistant strains. Cefiderocol is a Citro-4 beta-lactam, which is new in class. According to KDIGO guidelines, they also stress for empirical therapy to initiate on local the antibiotic as per the local resistance pattern, and for rapid de-escalation. For recurrent UTI, the KDIGO stresses upon using non-antibiotic strategies and to evaluate for the anatomical causes, and to also rule out fungal colonization. The European Association of Urology, their 2024 guidelines, for severe UTI like pyelonephritis and urosepsis, they stress upon using empirical broad spectrum antibiotics with early de-escalation, and to monitor closely for fungal infections. The ICMR AMR guidelines 2023, they asked to avoid fluoroquinolones, and for carbapenem resistant UTI, they asked to use ceftazidime avibactam, colistin, and cefiderocol, and also using the MIC values. They also asked to reduce the carbapenem use by promoting alternative beta-lactam combinations that we will discuss, and Arpita madam will discuss about that. So regarding the current guidelines, the key takeaways of various guidelines is to restrict the broad-spectrum antibiotic use and focus on targeted therapy, to prioritize the culture-based treatment and de-escalation, use carbapenems only for the confirmed resistant cases and not empirically. They encourage infection control measures and to promote non-antibiotic alternatives for recurrent UTIs. So here is, so that is why the antimicrobial stewardship is important in transplant UTI. So it will help us optimizing the selection, dose and duration, minimizing the resistance patterns and ensuring patient safety and graft survival. So here is the proposed antimicrobial stewardship goals in UTI post-transplantation. The most important ones, apart from the various guidelines we have discussed, is to take proper drug history. And as Kalra sir and Nitin Kapoor sir had previously told, the drug history regarding SGLT2 inhibitor, pioglitazone, saxagliptin, it's important because it's linked with higher chances of UTI. Then we should emphasize upon the preventive measures, which include hydration, catheter management, and hygiene. So what are the challenges, where we are going wrong? So there is overuse of broad spectrum antibiotic by us, and there is, we are not differentiating the empirical and targeted therapy, and there is lack of consensus on the duration of treatment. Coming to the empirical therapy, which is the initial treatment that we do before the culture results come. So the advantage of empirical therapy, to stress upon proper empirical therapy, is that rapid treatment initiation is crucial in immunocompromised patients. It prevents the progression to severe infections and reduces the early complications and hospitalizations. But there are many challenges, like risk of overuse of broad spectrum antibiotics. It may lead to inappropriate antibiotic selection if local resistant pattern we don't know or we are not implementing. So we need individualization of therapy. So to individualize the therapy, we propose a MDR risk stratification framework. So we can stratify our patients into low risk or high risk for MDR as per the time post-transplant, the previous UTI history, immunosuppression level, comorbidities like diabetes, the EGFR, presence of neurogenic bladder, structural urinary tract abnormalities, recent hospitalization history, previous MDR colonization, recent antibiotic use, the geographical and local resistant trends, healthcare exposure, recent urological procedures. So these are the various factors by which we can stratify our patients for MDR risk into low risk and high risk. In low risk, we can start with narrow spectrum antibiotics and de-escalate as early as possible. For high risk, we can start with broad spectrum antibiotics. We can reassess after 48 to 72 hours, and we can optimize based on the MIC and the pharmacodynamics and pharmacokinetics of the drug. Second thing that we propose is the stratification of antibiotics. The antibiotics we can stratify as per the CARE protocol. CARE stands for core, alert, and restrict. So the core group of antibiotics are the antibiotics which form the foundation of empirical therapy in our outpatients. And these are readily available, and we can use them in low risk of AMR. Alert are the second group of antibiotics. These are those which are the should be carefully monitored, and they have tendency to develop AMR. These also we can use in those who have lower risk of developing AMR. The restrict are the antibiotics which should be carefully chosen and only restricted to the severe infections. And these are the antibiotics we should use empirically for high risk of AMR that we discussed. So here I will also discuss the pharmacodynamics and its the drug-drug interactions. So coming to tacrolimus, so with fluoroquinolones, if we use tacrolimus with fluoroquinolone, it increases the QTC interval, QTC prolongation happens. With vancomycin, colistin, and polymyxin, there is increased nephrotoxicity with tacrolimus, and with clarithromycin, it increases the level of tacrolimus because of CYP3A4 inhibition. With MMF, ampicillin increases the level of MMF because of decreased renal clearance. Amoxicillin, it decreases the level of MMF because of increased enterohepatic circulation. Prednisolone, with fluoroquinolones, there is increased risk of tendon rupture. With clarithromycin, there is increased prednisolone concentration because of CYP3A4 inhibition and because of the P-glycoprotein efflux mechanism. So the targeted therapy is the therapy which we can use after the culture sensitivity report comes. But there are many challenges implementing the targeted therapy, like delayed treatment initiation if culture take time. It requires a robust antibiotic stewardship program, and it is not always practical in unstable or critically ill transplant patients. So MIC value is very important. Once we get the culture sensitivity report, urine culture sensitivity, we don't often look upon the MIC values, but MIC is very important. It is minimum inhibitory concentration. It is the lowest antibiotic concentration that prevents bacterial growth. MIC guides antibiotic selection. And in transplant patients, higher dose exposure may be needed because of the altered pharmacokinetics and dynamics. So if MIC is low or equal to the breakpoint, it is sensitive and we can use the standard dosing. If MIC is near breakpoint, we should consider higher dosing or extended infusions. If MIC is exceeding the breakpoint, it means it is resistant and we should avoid that antibiotic. Also, there is lack of consensus on the duration of treatment. So current guidelines, IDSA and KDIGO, they recommend 5 to 7 days of treatment in mild UTI, but EAU, the European Association of Urology, it recommends 7 to 10 days. Regarding pyelonephritis, usually we treat with 10 to 14 days, but newer studies, they suggest 7 days treatment is also efficient in those who are stable. Regarding urosepsis or bacteremia, 14 plus days are the recommended choice we implement, but recent trials show that the lower duration can also be equally effective. So whether the less is more, whether we should decrease the total dose of antibiotics so that we prevent the antimicrobial resistance. Also, we should have the strategy for oral step down whenever it's appropriate, and we should monitor the response as we do check the dialysis adequacy. The antimicrobial adequacy should also be checked, and we can find out as per the patient's profile whether the patient is improving. So likewise, we can adjust the total duration of treatment. The UK Health Security Agency, they have given an antimicrobial stewardship toolkit, and they say to start smart, then focus. So we have adapted this protocol as per the transplant UTI, and as per the start smart, then focus protocol, we should start with risk stratification that we have discussed into low risk and high risk as per the MDR risk. Then we should initiate the empirical therapy wisely as per the care protocol we recently discussed. Then we should optimize the dosing of the transplant patients as per the care protocol. We should reassess at 48 to 72 hours and review the culture results and adjust therapy as per the MIC values, which we often neglect, and we should de-escalate whenever appropriate. Then we should also determine the optimal duration of the treatment as we already discussed. The diagnosis should be prompt and right, that is very important, and to tackle the MDR timely. So gone are the days when we used to get the culture reports in days and weeks by the conventional methods. Now there are non-conventional methods like genomic sequencing and the mass spectrometry, and there is infrared spectroscopy. By these methods, we can get the culture reports within hours, and we can also get the gene sequencing by which we can have the resistance pattern also. As already discussed by the previous speakers, we should promptly treat the recurrent UTI, and there should be judicious treatment for recurrent UTI. And for that, we propose that for prompt diagnosis of recurrent UTI, rather than taking 1 year of the standard timeline, we should decrease it to 6 months. So whenever there is more than 2 infections in 6 months, we can take it as recurrent UTI. That will help us early detection of recurrent UTI, and early treatment can help us reducing the MDR risk. Regarding the multidisciplinary care, Dr. Pawan has already discussed. Adjuvant therapy is already discussed by Kalra sir. Then there are 3 concepts. One is the immunosuppression stewardship, and I will not go into detail of the 3 different stewardships, which is very important to tackle the MDR. One is immunosuppression stewardship, that is very important. Then urinary catheter stewardship and SGLT2 inhibitor stewardship. So we should know when to place the catheters, when to start the SGLT2 inhibitor, and how to decrease the dose of immunosuppression. But many often the first line therapy fails. So what is next once the first line therapy fails? So we should reassess the infection and modify our approach. We should confirm the treatment failure and check for non-microbial causes. The common resistance mechanisms, these will be discussed by Arpita madam also, but the most important is ESBL producing enterobacterials, and these are the genes implicated. The alternative treatment options in ESBL producing antibacterials is cephalosporin avibactam, Javisepta, the meropenem varobactam, or fosfomycin if susceptible. However, we should avoid cephalosporin and fluoroquinolone because of high failure rate. In carbapenem resistant antibacterials, the most important genes implicated are KPC, NDM1, and OXA48. For KPC, we can use Javisepta. For NDM1, we can use cefiderocol or aztreonam with avibactam. And in OXA48, we can use polymyxins and digicycline. In Pseudomonas aeruginosa resistance, which is the gene implicated is AMPC overexpression or OPRD loss, the treatment can be with ceftazolin tazobactam or cefiderocol. However, if there is OPRD loss, then we should avoid the carbapenems because it's not effective in that condition. In colistin resistance, the genes are MCR1 and 2, and here we should not use monotherapy. The combination therapy should be used, which is ceftazidime avibactam and aztreonam or cefiderocol. So monotherapy should not be used here because it's ineffective. So once the first line therapy fails, we should always reevaluate the infection source and resistance patterns. Genotypic resistant testing can guide us for the precision therapy. New beta-lactamase inhibitors are available. Combination therapy may be necessary for highly resistant pathogens. There are some salvage therapies, future approaches also like bacteriophage therapy. There are monoclonal antibodies available like AR105 against Pseudomonas aeruginosa. Then there are CRISPR-based antibiotic resistant gene editing, which is available for the research purposes. So in the end, I will discuss about the policy changes which are needed for antibiotic stewardship, and it's taken from the WHO antimicrobial stewardship program. So we have modified it accordingly. So there should be transplant antimicrobial stewardship team in every hospital. It's called TAST. Then there should be formulary restriction of high risk antibiotics. We should have audit mechanisms, and we should educate and aware our fellow clinicians. So what are the policy, who should be the policy holders for the TAST? That is the slide. It should include the transplant physicians, the surgeons, the infectious disease specialists, the microbiologists, radiologists and pharmacologists, and also transplant nurses. The formulary restriction of high-risk antibiotics, we should have pre-authorization requirement for the high-risk antibiotics. We should have a tiered access system for them, and we should have real-time pharmacy alerts so that we can get alert whenever high-risk antibiotic is being used. We should have regular audits. The audits can be prospective or retrospective. So what are the key takeaways, what we have learned? The stewardship is not optional, it is essential. Shorter targeted therapy should be used whenever possible. Rapid diagnostics will transform the UTI management. How can we apply this into our practice? We should audit our own prescribing patterns. We should engage in local antibiotic stewardship programs. We should educate our colleagues on responsible UTI management. So stewardship is a shared responsibility. We should commit to smarter prescribing and advocate for institutional stewardship policies. Thank you.